Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. Hello, everyone. Welcome to the Microdosing for Healing podcast. I am so excited to introduce you to our guest today. In prepping for our talk today, if I could trade brains with anyone, and I like my brain, it might be this guy you're going to meet today. He has had the most remarkable life of service, among the most I have seen. And I'm so excited to share him with you all today. When I was reviewing his background, his CV is 14 pages long. And when I met him, he told me it's just so long because he's old. And I can say that is not so. It's incredible. So I'm so happy for you to meet him and dive in today. Please meet Dr. Robert Strayhan. Robert, thank you for being here with us today.
Thank you for having me.
Yeah, so I'm just going to read a very brief snippet of his bio for you to give you a flavor of his background. So he has been in the field of psychiatry for a long time. He completed his residency at Wilford Hall Medical Center, USAF, in 1987. He's currently the Psychiatry Residency Program Director at the Unity Health System and a 2021 graduate of the CIIS Certificate Course in Psychedelic Assisted Therapies and Research. He has most recently served as the Director of Mentoring and the Instruction Supervisor for the CIIS program and has completed the 3-year program of Advanced Initiations in Shamanism and Shamanic Healing. He also completed the red phase of Sangama training under the tutelage of Gogo Ekaya Esima. How'd I do? Great. And Dr. Strayhan has also been a longtime martial arts practitioner, having studied Tai Chi, Wing Chun, Taekwondo, Budo, Taijutsu, and the Russian martial art of Sistema. Beautiful. All right. Thank you so much, Dr. Strayhan. So to dive in, my first question for you, we're at this inflection moment of psychedelics being brought into our mainstream medical healthcare systems. And so given you have been in the field of psychiatry for very many years, have had very diverse experience in the field, I would love to hear your thoughts overall on the pros and cons of placing and incorporating psychedelic medicines into the existing frameworks of medicine.
Well, I think the first hurdle is that allopathic medicine and to a lesser extent, osteopathic medicine, we have our rituals and we have our belief systems and we have our levels of proof. And currently the standard for effectiveness for the new medications is whether or not it's better than placebo. And the ruler or measure is the placebo-controlled, double-blinded, randomized clinical trial. However, I think a big hurdle for that is when you look at human beings, our brains have 86 million neurons. And human beings of Homo sapiens have been on this planet for 100,000 years. These psychedelic medicines have been used for at least 70, maybe 100,000 years or more. So there's a knowledge base, there's an experience base, and people still do those things because they work. So with our current evidence-based approach, it ends up being a situation, in my impression, where a lack of evidence really is determined by how you measure it. So if I had a temperature, I wouldn't put a blood pressure cuff on. I'd get a thermometer. So I think the current way that the FDA approaches the approval of psychedelic medications is probably not the best tool. I mean, there's adaptive clinical trials that are more mobile, where you can change with the populations. You can actually give different doses. It ends up being a little bit more expensive, but it ends up being more flexible than what we have. And I think there's not a lot to have as a frame of reference, because none of our current psychotropic medicines has anywhere near the effect on consciousness that these medicines have. So it's like the hard question of consciousness is why we have it at all. The easy question for consciousness is why does it happen, which is also extremely hard. So we don't have any of those details, any of those things that winds down to a simple, oh, this is a serotonergic problem, or this is a dopaminergic problem. I mean, it goes beyond neurotransmitters. Um, and I think when the FDA said, well, we don't govern the practice of psychotherapy. Well, but almost any psychiatric, how shall I say, guideline says that combining psychotherapy with medications is always better. So again, when I didn't see anyone asking them to govern psychotherapy, but I saw them in the MDMA trials using what is basically a given agreement that this is the standard of practice, that music is a concomitant, uh, blindfolds is a concomitant, taking into account set and setting is a requirement. So they did standard of care, although we haven't agreed nationally on what that standard of care. I think there's a consensus by how shall I say, a respected minority that this is it. So I just think that the mechanics of it, the rituals end up being like the article that we discussed. Is it a placebo or is it a tomato? So the common knowledge back years ago was tomatoes were poisonous until somebody ate a bunch of them and didn't die. Then everybody started eating them. Um, so psychedelics are bad. You have all these, if you're as old as me, you remember the egg dropping in the fried pan, and this is your brain on drugs, and the mythologies or over magnification of people who had bad experiences with LSD or other medicines. I think similarly to the comedic things like Reefer Madness, if anybody's seen that show where one smoke of reefer turned the guy into a murderer and all those other things. So I think there's these prejudices. I think there's a lack of familiarity with the research with these medicines. And I think there's a certain amount of fear, because there this isn't something that can really be controlled. I mean, everyone could have a different experience. Um, and even from the standpoint of expectation, most people who take the psychedelics in a clinical setting don't come because they think it's not going to work. Um, and that's part of the deal too. So I think, I hope that the FDA will say, look, we knew about all these problems all along. Uh, it's nice to have the advisory committee's input, but we're still going to approve with whatever changes that they feel is necessary, which I feel ultimately will be a risk evaluation and mitigation system, which is fine. Um, Everybody won't be able to prescribe it, and everybody shouldn't. But I think the other thing is we would be doing a great disservice if we only thought MDMA could be used for post-traumatic stress disorder. I'm hoping that decriminalization will take over so that reputable people who are doing good work underground can bring that work above ground, so that people can pursue the use of these medicines for things that they've been used for millennia, to be a better person, to better serve your tribe, to expand your consciousness, to connect with something bigger than you. So I'm hoping that those things will occur. And I think due to Michael Pollan's books and some other things, there's less social resistance to it. But as to stop along with the commentary, we have our rituals, the white coat, the office setting, how we interact with people, how we perform physical exams. I mean, there has to be, in my way of thinking, some degree of flexibility in dealing with this because this is uncharted territory for most of my colleagues who have no experience with the psychedelic, except they've heard all the bad stuff.
Mhm. Thank you. One of the things I talk about often with colleagues who are doing direct work in the space is the friction between the reality of the work, of doing the work, and kind of the trying to put these silos over and this homogenization over this work. Because if you're doing the work, you see one person loves an eye cover, the next one doesn't want an eye cover. One person loves music, the other one doesn't. One will want to be in a closed room, one wants to be in open space and nature. And that's a big part of the work, is being able to draw from different backgrounds and different experiences. So I'd love for you to speak to, you have such an eclectic background beyond medicine. You've trained and studied so many things. So I would love for you to share some of those things and how those practices, African shamanism, combo training, yoga training, have informed the way you hold psychedelic practice.
I think for the standpoint of FDA approval, then certainly um, identical standards, or as standards that are how shall I say, across the board for individuals. Say each person should receive the same music. Each person should receive the same psychometric test. Uh, each person should be included in the protocol a certain way for research purposes. But in my ketamine practice, although I was taught that you need to provide a playlist, I've never provided a playlist for my ketamine patients. I asked them, what music would you prefer? Um, and that's the start for me, because that gives them some degree of agency too. So I don't want to play yoga studio music for someone who has no familiarity with it, or they may not like it. Um, Funny part was I had one young man. Um, I told him, I said, well, you could probably play any kind of music except death metal. But he said, but death metal makes me feel good. So I let him play death metal. um, so some people will say, particularly some of the women here in our community are really strong in the Church of Christ, and they want hymnals with words. And so I said, okay, let's do hymnals with words. Some people don't in the beginning want to use the blindfolds, but then some of the visual things are, then they're like, well, let me put the blindfold back on because it keeps this more of an internal focus. But I think there's another fear of the music selection is one thing, but how you influence the setting is another. I mean, I don't think there's anything wrong with asking a person about their cultural preferences and asking them, is it okay if I smudge? Uh, would you like to pull an animal tarot card? Uh, would you like to hold on or bring certain objects that you feel are significant to you? Or before you go in, would you like to see a picture of what you want to focus on? uh, and agree on those things beforehand, unless it's something that's dangerous to the patient, or if I think it's going to be harmful to them. I'm like, okay, I don't know how it's going to turn out. You don't know how it's going to turn out, but let's try it and see. And if it works, then we'll continue. But the the shamanic aspects of it, and I think there's actually an approach in one of the books written by Dr. Harner's wife. Uh, is called Emma's Odyssey, and it doesn't involve psychedelics, but it takes the person into non-ordinary realms of consciousness, and there's nothing directive about it. It's they go to the upper world, lower world, middle world. They have a question. The Either the human guide or the animal guide gives them feedback, and they bring that back and we work on it in the setting. So What did you learn from your travels? And learning how to do that kind of travel is not really complicated. I mean, most people can learn it in at least a day or two. So I ask people, what have been your experiences, not only with the medicine, but with things like meditation, because people can have those types of feelings too. And if they say, I don't need music to get there, okay, that's fine. Let's do the ketamine and see what happens. Or I need, how shall I say, a certain type of setting to put me in the right frame of mind. So in the rest of the decoration of my room, I have enough things that have a cross-cultural reference that um, if it's Christian and they want to focus on angels, then they can see an angel. If they're from African American descent and seeing uh, Ogun uh, or Shango, I mean, fine. I mean, they can have all of those things. So, and if someone says, I would rather you bring something in, that, I really, Dr. Strayhan, I think you could have more Native American decor in here. And I would say, okay, let me see what I can get to help make you comfortable. So I just see it as this honor to be able to sit with someone. But I just know that the more I work with this, I have an idea, but I never know how it's going to turn out. So that part of the experience, the shared experience being in that space keeps me humble. Because again, I would never hold myself out to be a shaman, though I've had a certain amount of what people would characterize as neo-shamanic training. I was taught you never call yourself a shaman. Someone else may call you based on your efficacy, based on the outcome, but I think I would never do that. But I tell people this is your journey. I'm here to assist you. I'm here to walk with you in the journey. And if things get tough, then we'll get through it on the other side. Um, so no, I've found that I've been able to use those things. Say, for instance, with African Americans, not all, but some will have visitations with ancestors. Uh, So I can't tell them, oh, well, that means this based on why do you think you saw grandma? And what did grandma have to say to you? And what did grandma showing up mean to you? I mean, was she different in any way? So to a certain extent, some of uh, Jung and Freud's dream work, it's like, okay, mom appeared, but she had hands like so and so. What do you make of that? So this condensation, and I think the more that I have in my toolbox allows me to bring more to bear in support of the patient. Doesn't mean that I know everything, but the things that I don't know, then I'm curious enough to ask. Point me in the right direction. How, what, what direction can you point me in so that I can understand better your life's narrative?
Mhm. Beautiful. Thank you. I am psyched to ask the next question of you, which is, you've had such an extensive experience with mental illness, mental health. And one of the things, especially right now, that's coming up for me this year is I'm seeing so many kids and young adults and parents of struggling younger people and in the realm of mental health. And the question becomes, is the mental health issues innate or is it cultural? And right, and I would love to get your view because I my sense of the paradigms we have been coming from and all of the emphasis on pharmaceutical interventions are based on something being wrong and deficient in the person versus something being wrong and deficient in our society and our culture. So I would love for you to get your reflections on this subject, given your expansive experience.
I think one of the things from a cultural standpoint, at least in the West, is that we don't have rites of passage. We don't have anything that marks our entry into our community as blank. So, and I don't think it needs to be anything along the lines of uh, the extreme lines of female genital mutilation or things like that. But people people got to a certain age and they were expected to go through this ritual. And it wasn't so severe that everybody would fail. It was designed to see what type of person you are, where your head is, where's your focus. And then once you pass that, then you were introduced to the community and said, this person is a fully functioning individual. Uh, this person is ready to assume certain responsibilities in the service of the community. Um, we don't have as much of those community things. I mean, now we have people, kids and adults who are on social media all the time. I mean, I have 100 friends. Oh, really? How do you have 100 friends? Well, they're friends on Facebook or they're friends on X or no. How have you actually interacted with someone? How have you dealt with this other person's feelings or expectations or how they behave? Because if something gets uncomfortable, all they got to do is unfriend them or not answer back. So there's nothing that guides people um, through these life stages. We don't ready our teenagers for things like that by and large. I mean, even from the standpoint of the power of the feminine menstrual cycle. In some places, feminine menstrual blood is really powerful. I mean, if you're talking about mojo stuff, then there it is. Uh, But marking that passage into womanhood, marking that passage into manhood, we don't have those things in a ritualized or ceremonialized form. I mean, now it's not everyone, but now it's did you graduate from high school? Did you graduate from college? Or how many people you can beat up? Or how many girls you can have a sexual conquest with? Or I mean, things that don't help the community, things that are based on a team of three, me, myself, and I. So there's not a Ubuntu principle to it, as when Nelson Mandela and Archbishop Desmond Tutu, uh, there's no I without a we, but there was well, I did this, I did it. I'm a self-made man. No, you aren't. I mean, if you look at it, I mean, all right, this cell phone, I didn't make this. How many people did it take to make this? All these different parts, put it together. Who drove the truck? Who made the highway? Who put it on the shelf? Who rang it up for me? Nobody exists in a vacuum, but we tend to give people the impression that you're all alone. And if you make it, you make it. If you don't, something's weak about you. But the other patterns are you're always part of a community. Not being a part of the community was something that was really dreaded by people in the past. Now it's kind of like, I don't care because I got friends on social media, or I can have a virtual friendship. I can have an AI generated friend who does everything I wanted to do with no feedback. I had one patient tell me that, well, I don't need a therapist. AI is much better therapist. Why? Because the AI doesn't criticize me. The AI never questions me. And I was like, you're not getting therapy.
Indeed. Indeed. Um, I would love for people listening. So many people I have found don't really understand how drugs and pharmaceuticals get born, so to speak, right? And the process and why there's so much emphasis on them. Like we see the result of as a consumer and the extreme marketing and, turn on any television program and you're just inundated with pharmaceutical commercials. So could you just give listeners a quick explanation of how drugs get born, like how drugs come to market?
First of all, there can be, well, let me back up. The vast majority of our psychiatric meds, or the parent compounds for our psychiatric meds, were discovered by accident. Um, so I'll give an example. a medication that was initially intended to treat tuberculosis was found to be an antidepressant. Uh, and for lithium, lithium was being used as a salt substitute in a large psychiatric hospital in Australia. But he found out, hey, these bipolar patients who are getting the lithium, they're getting better. So these things were accidental, similarly to the LSD. I mean, LSD was synthesized a long time ago, put on the shelf. He took it back off. He spilled something. Oh my God, this is something different. And for a while, it was given to anybody who wanted to use it to how shall I say, simulate a psychotic state. So a lot of these quote discoveries were based on accident. But a lot of our newer developments are really running into how shall I say, a dead end because finding a new molecule, finding a novel molecule that does something different is really hard. So if you take it from the bench to the consumer, then you have to look at this molecule, you have to refine it, and the FDA has 4 phases that you take the medicines through. So one is, can you give it to normal people and basically it doesn't kill them? What kind of side effects does it have? What have you? Then you try in phase 2 to find the correct dose, a dose that gives some sort of signal that is still safe, but that there's some tendency of it may be helpful for the condition. Then in phase 3, you expand it, you get a lot more people. Then here comes the part about the randomized placebo-controlled aspects of it. And when the advisory committee said, well, the placebo, it's hard to mask the placebo effect. Everybody knew they were getting it. Well, yeah, it's hard to give something inert and not be able to tell the difference between I got MDMA or I got LSD. I mean, you know. And so that's an easy way to do it, but again, another way to do it would be to give a lower dose of the active ingredient so that you do feel something, um, and then give the test dose. But again, I digress. But phase 3, lots of numbers. Then you can submit to the FDA a new drug indication and an application. And while you're waiting on that, you keep doing numbers. And if you get approved, then you go to phase 4, where you do even more numbers, and then you continue to see if the medication is safe. But generally speaking, after you've gone through those things, then you can put it to market. But if you look at all the money that went into the trials, if you went into all the money that went into synthesizing the how shall I say, the test drug, then they're going to want to recoup it. And if they have people who are investing, let's say you tell someone LSD is going to be good, or this molecule, this variant of LSD is going to be good for, I'll say, anorexia. And then you have investors say, okay, I think that'll work. I'm going to give you X amount of money, blah, blah, blah. Then once you got that, then those investors are going to want a return. Matter of fact, they're not going to want just what they put in. They're going to want more. So you advertise it, you have the little cute little butterflies and all the other things that come out and say you should use this and ask your doctor about it. And then they're required to say what the side effects are. But that's when the flowery stuff stops. Then they say, and then you can have and if you're allergic to it, how would you know you're allergic to it? But but and they
Exactly.
talk really fast when they talk about those things. But again, there's the profit angle, and some of the tension with the psychedelics, particularly the naturally occurring ones, is you can't patent uh, those medications. But if you have a new drug, you can patent it, and nobody can use that particular drug for 10 years. So you get to get all the profits from it for 10 years, and then at 10 years, you can go generic. So again, to use, say, for instance, Prozac as an example, Prozac made an awful lot of money for 10 years. then they said, okay, we can't lose this. So they started doing things like, let's call it something different, but let's say it's good for premenstrual syndrome. So I had a lot of ladies running, and it was film something, but I had ladies coming in and say, "Oh, I got a good medicine for PMS." I was like, "Ma'am, you taking Prozac?" She said, "No, I'm not. I'm taking blah blah." I said, "Look on your label and see what the generic says. Fluoxetine." I said, "Now look on your Prozac and see what the label says. Fluoxetine." So the other marketing strategies and things that make it expensive or contribute to the expenses, like with ketamine, uh, they took the the levorotatory isomer of ketamine and called it Spravato. We're going to give it nasally. But when they did those trials, only one of them had statistical significance, and they fast tracked it through. And to be honest, it's really expensive uh, in comparison to racemic mixture ketamine. Um, but you can get insurance to pay for it, but your copay is really high. I've, I mean, I won't say it's a racket, but the profit angle in medicine is really astounding. I mean, how much money can be made off these meds. And the other thing that I'm going to say is sometimes our system is not based on wellness, it's based on illness. So I won't go so far as to say that's the sole determinant, but if everybody got better, then there wouldn't be use for a lot of the things that we do. So there's not a lot of money put into prevention. There's not a lot of money put into what can we do for you before you get sick. So in contrast to what a lot of people say, well, if everybody took psychedelics, the world would be a better place. It's not necessarily true, but I've given ketamine to people as young as 15, and I try not to go much lower than that, particularly when they're still having imaginary friends or their grasp on reality isn't the greatest. But teenagers are able to process it. They're able to sit with you, and some of those things that they have that I've treated them for aren't, because with ketamine, nobody's going to ask me whether it's on label or off label. It's all the use is off label as long as I follow a protocol. But I've had some of the teenagers deal with self-esteem issues, which were expressed as depression, or self-esteem issues, which were expressed as anxiety. So I was like, I'm not going to give them an anti-anxiety medicine. Let's look at the stage they're in. Let's look at where this is coming from. And then sometimes the ketamine helps them nail that down. They come out of it like, oh, I didn't know. I didn't know other people really loved me. I mean, yeah, they do. But then they really love me, and they're telling me that I'm this person who's worthwhile and capable, and maybe I should believe them. And then you keep going. So the ketamine is not the cure anymore for the adolescents anymore, so than it is for the adults, but it opens things up for therapy. So no, I mean, I require all my ketamine patients to have a therapist. I can help them with the integrated part, but I don't fool anybody. If you're not doing therapy and you're just doing it to get the feeling, no, I'm not going to keep prescribing it. This is work too.
Mhm.
There's no magic pill. This is not like the Matrix. It's not the blue pill or the red pill. You have to work.
Mhm. Mhm. Thank you. I want to switch it up a little bit. Now, I love asking my guests doing a little speed round with you if you're game. Favorite psychedelic?
You know, I don't have an extensive experience with psychedelics, and strangely enough, I seem to respond to almost everything the same way. I mean, I get some sort of response from combo that other people don't get. It seems like I get with Wim Hof breathing. I mean, I get a response. With holotropic breath work, I get a response. So I think the way that I've approached things, and based on my background, I won't say that I can enter into a non-ordinary state of consciousness in a variety of different ways. But maybe it's because I'm older, maybe it's because of my experiences. I almost always end up in the same spot. So far, I don't really have a favorite. Um, I've been through a couple of challenging experiences that I thought were like a hell realm. So basically, I got into a loop and I was
Mm-hmm.
like, okay, I'm going to come out of it. Oops, there it goes again. I got in a loop. Oops, okay. And I thought, crap, is this what hell is like? I mean, I'm stuck in it. Am I going to be stuck in this forever? But I remember what Bill Richards said. Uh, said, breathe, fall into it, and see what it has to teach you. So things were rotten until I said, okay, if I'm in hell, let me sit down and see what it has to teach me. And it stopped. It flipped. So I think for me, the experience is pretty similar. The gateway is different. And the other thing is, um, because I'm an old guy, some of the things that I've gone through are ordeal related, the fasting, some of the physical things that I've gone through. Uh, so I almost always end up in the same place. So long story short, I really don't have a favorite. Um, Usually somewhere along the line, uh, I confront shadow aspects. Um, there's a really good program. Oh gosh, I'm blocking on his name, but he's in Boulder, Colorado. Daniel McQueen. He has a program that he uses ketamine and psychedelic grade marijuana in combination. So the ketamine takes you pretty much out of your system. The psychedelic grade marijuana really puts you back into your body. Um, so one of the ketamine processes, I fell into a K-hole type situation where I couldn't move, couldn't talk. I wasn't really where I was breathing, and that could have been one of those, oh crap, I'm dead. But they prepared me for it. And the shadow says, I'm back. I was like, yeah, I know you're back. So he says, well, what would you do if you were trapped in here with me like this for the rest of your life? And I wasn't necessarily liking that because when the shadow comes out, it usually tells me things I don't want to hear. But it said, but you are trapped in here with me for the rest of your life. So you might as well learn how to dance with me. And then we came out and we processed it. So again, I have more experience with the ketamine, but combo kind of did the same stuff for me. I'm a little bit different.
No, I love it. I love it. Uh, Psychedelic mentor.
Mm, okay. I've really learned a lot from Bill Richards. Um, Bill Richards is one of the kindest people that I know, and he has a wealth of information. He wrote probably his first paper when I was 5 years old. Uh, and Bill has been very kind. And if I call him now, he'll answer me. And he doesn't say, this is what you should do. He'll say, well, what did you learn? Um, or what are you trying to learn? And so I would say probably the most significant person of of note that I've met has been Bill Richards.
Beautiful. How about psychedelic artist or musician, if you have one?
I don't, but part of the things that I have done is I've noticed, I've gone back and looked at the history of African Americans in the psychedelic realm. So I tell people, if you don't think Jimi Hendrix was psychedelic, okay, then there's George Clinton, um, There's the Temptations even did things like that. There's a song called Psychedelic Shack. I mean, if you look at Motown, you can find those types of things. And then you dive into it a little bit deeper and you find that some of the let's see, Coltrane, him and his wife were deeply into psychedelics. So there's this undercurrent that the general population, much less African Americans, are unaware that it happened. This stuff didn't start with ASAP Rocky taking LSD and then urinating a rainbow. It didn't start with Will Smith taking ayahuasca. There's always been that. And the other person from that standpoint that's really been helpful to me is Gogo Ekaya Esima. It was a non-psychedelic approach, but completing the red phase with the brews that are prepared. I don't think, okay, it changed my sleep pattern, changed my dreaming pattern rather. I can, if I go to sleep for 15 minutes, I dream. If I go to sleep with the radio on, I'll start dreaming or something on the cell phone or TV. I'll start dreaming about what's on the TV, which can make things pretty interesting. I was fell asleep listening to a documentary about uh, uh, Heinrich Himmler, who's a Nazi, and all of a sudden, then I'm dreaming about talking to Heinrich Himmler and forgiving him for the things he did. We hugged. So it's like, but there's different types of things. Like I have ordinary dreams, then I have some dreams that are like that, influenced by what's going on around me. And then I have these, for lack of a better term, alternate reality dreams, like I'm somewhere else, and this is something that could have been happening to me in another reality, which I have to be careful not to mention that to my peers, otherwise I'll be recommended for hospitalization and Mobile and certain other medicines. But um, these, I would just like to say to people that you can, the old adage of if you're looking for a teacher, then you'll find them, or the teacher will find you. And I've been fortunate enough to have found teachers that I can
Mhm.
trust and who are invested in my growth and have made a safe holding space for me.
Thank you. Beautiful. I'm so curious to ask you about your childhood and what you
Okay.
were like as a kid, because especially I'm just completing one of my microdosing immersions right now, and this week in our groups, we got talking a lot about how much focus these days is on our traumas, and fixing our traumas as kids, and kind of in talk therapy, going over and over and over the story of things done to us and things we lived through, and in focusing on that, especially in childhood, we miss our gifts, and how much more fulfilling it would be in our society, speaking of rites of passage, if we helped children recognize their gifts and develop their gifts rather than just focusing on their trauma. So I'm so curious, given given your life's experience, what you were like as a kid in
Okay.
your childhood. Yeah.
I grew up in the 60s when Jim Crow, segregation, uh, and racial hatred was much more open. Um, I grew up in a time where mm, if you and I were to have met for a coffee, someone might have objected to that. I could have got killed, and you would have been labeled basically a race traitor. Uh, I couldn't drink water out of certain fountains. I couldn't go to certain bathrooms. Uh, the Dairy Queen, the restaurants in the small town that I grew up in, we couldn't be served in those restaurants. There was a special window, either on the side or the back, where quote Black people could. The term then was colored people or Negro, and I have a problem with Negro because French is one thing, Spaniard is another thing, but there's not a country named Negro. So I mean, there's a color, but that was the way things were. But there was this danger uh, around me all the time. But I was raised in a supportive brown skin environment. My parents never taught me to hate. They said, there's nothing wrong with you. They said there's something wrong with them. And if they ever took the time to know you, they wouldn't hate you. Lots of physicality, got into lots of fights because people objected to my skin color. But I found out when I helped integrate my school in the seventh grade that people were people. Um, all Black people weren't my friends. All peach skinned people, and I use brown and peach skin because when you open up a crayon box, none of us are Black. I mean, we're brown, different shades of brown. And there aren't white people, they're peach skinned people. I mean, so these racial constructs are things that I've never really abided by. But I think the thing that really changed me and put me on this path was we had white waiting rooms and colored waiting rooms, even in the doctor's office. So the room where we were was pretty crowded, didn't have a lot of room. But I could look into the other space and the little kids were running around and they had lots of room and yada yada. So I asked my mother, I said, so mom, I said, they got their doctor. I said, why don't we have our doctor? And she looked at me with all her seriousness that she's had. She said, well, I guess then you'll have to be one. And that was it. That set me on the road to being I didn't know how I was going to do it, but that set me on the road to being a doctor. So that was it. She said, maybe you'll have to be one. And here I am.
Mm, love it. Love it. I was reflecting, I had a thought and it led me to do some research and I want to read what I found. So I was thinking about the psychedelic godfathers today. And Rick Doblin was born in 1953, Paul Stamets 1955, Richard Alpert 1931, Jim Fadiman 1939, Terence McKenna 1946. And a lot of why we have the psychedelic godfathers that we do is at that time and era, they were the only ones who were allowed to do anything and to get credit for anything, right? And I know you have been active in working with systemic racism in academia. So I would love for you to reflect on kind of broadening the perspective in the movement and how we can continue working to do that.
Well, I've found that there's many people who have been willing to support me, even though I came late to the field. Many people have been helpful and supportive of me in my quest and in my journey. However, there still exists a glass ceiling in regards to research. So when I've tried to, how shall I say, put my CV out there and say, I've done clinical trials in the past. I'm ready to do this. I've gone through CIIS, I've gone through the MAPS training. The usual retort is, but we'd like to have someone who's done research. Well, I can't do research unless I get the opportunity to do research. And by and large, that's conducted by peach skinned people. There's usually a lack of BIPOC participants. I think part of it being the selection process, part of it being the location. So when Dr. Monica Williams, who's a giant in the field, uh, she was one of the first principal investigators for the MDMA. However, she was in Connecticut. Connecticut's not the most brown place, but she didn't get a lot of support based on what she said. And this is, quote, I didn't talk to her directly, but secondhand information that she didn't get a lot of support from the physician who was prescribing the medicine. So I think there's been a lack of investment in BIPOC people being principal investigators. And I think that's one thing. But I think the second thing is there are physicians who are qualified to prescribe the medications and be principal investigators. So when BIPOC people come in, if a non-physician is the principal investigator, they'll know that, but they'll say, but who's prescribing the medicine? I won't say that the person prescribing the medicine is the boss, but the clinical trial can't proceed unless you have somebody who's has that DEA schedule number 1 permit that allows you to do the research. And you can't get that DEA schedule unless, at least in Arkansas and Texas, unless you show that you're already affiliated with a research institute. So someone has to say you're on staff, someone has to show that you're able to do the research, and then you can get it. But again, it's that trap of you can't get experience if someone doesn't say, hey, for me, for example, and part of it is I can understand there's an ageism factor for me. People may not want to invest in me because I'm 68, but there are younger people who are able to participate in these trials, and we're not going out to HBCUs to recruit people uh, to be therapists or physicians. We're not reaching out to uh, NMA isn't as strong as it used to be. It's a National Medical Alliance, which was what Black people or brown skinned people joined when they couldn't join the AMA. So there's a lack of recruitment in those areas. So I'm not sure I know what the fix is, but I think a lot of the psychedelic industry has to do with 15 minutes of fame, and people aren't really willing, they may not be willing to share that platform. I hear people talking about, well, I've done research on this, I've done research on that. Well, how do I get to do that? But then when you ask those questions, then you get crickets by and large. I've gotten crickets. That may not be everyone's experience, but those are the problems that I see in regards to inclusivity. And when you look at it from the standpoint of women, women still aren't principal investigators in these studies. They're still men. So I think the psychedelic field has a similar challenge as what NASA had beforehand. NASA, the first pilots were test pilots. They were these cocky, wiry guys, all white males. But then, and I forget the lady's name, but she wrote a book called The Right Stuff. And so now, when we joke, and when the times I've been called to participate in astronaut selection, we would joke and say, back then they had the white stuff. So now there's more of, let's look at women, let's look at men, let's look at what they bring to the table. Everybody doesn't have to be a fighter pilot to be able to carry out the job. So, for instance, I mean, I've dealt with women who were combat veterans. They were just as qualified. Uh, they've been mission. I participate in the selection process. I don't participate in the training, but I've seen some of those people, women and minorities, turn out to be really stellar individuals. But whereas in the past, they didn't get the opportunity. So I think until there's active recruitment, there's active uh, expression of interest in having inclusivity, people will continue to assume, excuse my language, that these are white folks' medicines and these are white folks' things, and I'll have a table of my own, or I'll get my own organization. And there's nothing wrong with a table of my own. So it's a good movie and the people are sincere, but I in addition to a table of my own, I'd like to be able to eat with everybody else. I mean, it gives me the intimacy of being with people who share a similar situation, but I wouldn't want to join any of those organizations that would, by default, result in segregation, a self-induced segregation.
Thank you so much. I know one of your passions you expressed in getting into psychedelics and in a specific area of psychedelics is helping support people that have had long-term negative side effects from psychedelic experiences. So, can you talk a little bit about that and some of the training that you've done around that and that area?
I think that's an area where we could do better as well, because when you go to most of the psychedelic gatherings, people will say that there are no long-term side effects from psychedelics. And that's not true. I think they're less likely to occur in a controlled research setting because you can screen people in, you can screen people out, you can have exclusion criteria, inclusion criteria. However, most of the people that we're going to see outside of clinical trials aren't going to have that. They're going to be people who have comorbid conditions. They're going to be people who uh, have comorbid psychiatric and medical conditions that we have to consider. So I think my education has been what can happen and looking at the small literature that isn't sensationalized, because there's some people out there who demonize it and, well, those people at MAPS, they're lying and they didn't report everything. No, they're not lying. They didn't see it in that controlled setting. But outside of the setting, I've seen some people who uh, have had long-term effects, but the underground people who were doing the treatment or giving them the medicine didn't have an understanding of what could happen. So as a result, it's like, well, I don't know what to do. Or the worst advice I think is, well, you should take more and that'll help you get through it. No, I mean, there's challenging experiences, uh, and hopefully growth can come from those. But there are bad experiences, and some of those bad experiences need to be managed um, in a medical way or a different way. So I think people should be, if they're doing it underground, and this is not an endorsement, but if they're doing it underground, then they at least need to know somebody that they can refer the person to if medical intervention is necessary, or if further therapy that they're not familiar with, because some of the best underground practitioners probably aren't um, physicians or psychologists or even social workers. I mean, but I think it's kind of irresponsible if you're not prepared for the rare event. Who can I refer this person to? So just like with me as a psychiatrist, if someone's having a really severe cardiac problem, I'm not going to ask them how you feel. I'm going to refer them to the cardiologist because they do a better job of that than I do.
Mhm.
So most of my experience has been self-taught, but I'm hoping to be able to incorporate some of the things that I've learned and gleaned from the literature into CIIS and other avenues where that present themselves potentially like podcasts like this to say
Mhm.
this is, say for instance, there's HPD, hallucinogen persisting perceptual disorder type 1. Well, that's okay. It doesn't really last that long. And a lot of people say, okay, this is part of the experience, it's egosyntonic and everything. But then there can be HPPV2, which lasts longer. It's kind of like, gee, when is this stuff going to stop? I mean, it's interfering with my life. I don't want this to happen. So what do you do with those folks? Just tell them to sit and wait it out? Or do you refer them to someone who may say, here's a potential treatment, and a potential treatment besides strong antipsychotic medications? There's a small literature that says an anticonvulsant medicine uh, named Lamictal uh, has some utility for the treatment. So there's, how do I manage it in a supportive environment if it's a temporary experience? How do I manage it though in the long run? And it may require psychopharmacological intervention in addition to those other things.
Mhm. Thank you so much. I know myself and my colleagues who work with microdosing have noticed a strong uptick in the cases we've been seeing of people who did very little preparation and then went and did an ayahuasca ceremony
Yes.
as their first experience. And while they were functional, they described they were definitely destabilized more than they anticipated. And it was almost like they described it as therapeutic, but it was almost too much truth all at once.
Yes.
Right. So there's a spectrum of
Mhm.
integration experiences on the other side. Yeah, absolutely. Can you talk about, I know you trained with Dance Safe and
Mhm.
Zendo Project, right?
Yes.
And you're going to Burning Man this
Yes.
year. That'll give you some
Yes.
real time experience, no doubt. Yeah. Would you like to share anything about your collective experience in psychedelics and how you would answer someone who's just looking to get into the field? There's a lot of enthusiasm. There's lots of people wanting to get in. What would you recommend to someone who is coming from, say, just a layperson's background, but is drawn to kind of come in and support? What would you recommend they start with?
I and I have had some people ask, and I approach it from the standpoint of education in the pursuit of harm reduction. So I tell people, okay, so let's say you're thinking about using LSD. Have you ever used any other psychedelics? No. Well, I can't make a decision for you, but maybe a different start. Maybe something that's, how should I say, I won't say kinder, but less overwhelming.
Microdosing, maybe.
Yes, maybe
Yeah.
microdosing, maybe MDMA, maybe psilocybin, but no, LSD might be a little bit too much. But you have to make the decision, but I'll give you the information. The other thing is, if you're gonna do it, do you trust the person that you're doing it with? Does this person give you some indication that they have experience doing it? But given the entrepreneurial or capitalistic sides of it, you got people popping up all over the place saying they're qualified to do this, they're qualified to do this. And people don't know any different. But just as if you went to a shaman, you'd want to see if they came from a lineage. Who trained you? I mean, who trained that person? So it's not unreasonable to ask this other individual, what training do you have? Well, I don't have any, but I'm especially gifted, so I can no, you don't if you're having neurosurgery, you don't want someone to say, I'm especially gifted. You want somebody who's done it. Okay. So I tell them about that. The other thing that I ask them to find out is what does that person do in regard to follow-up? Are they available? If something happens, can that person help you or will this person even be willing to help you? The other thing I say is, okay, so you want the experience, but do you trust the person you're getting the substance from? And even if you trust the person you're getting the substance from, there's no guarantee that they're getting the real thing. So some of the literature is coming up now that I think it's diamond shrooms. It's this really quote innocent thing, but they're putting a bunch of crap in it. I mean, some of the things that people think are MDMA are super powerful amphetamine. There's even xylazine and all kinds of fentanyl that they're putting in. It's like, so if you're going to do that, even if you think you're getting it from a reliable source, you possibly should consider testing what you got before you ingest that, put that in your body. I mean, so there's all sorts of things to prepare for it and to increase the odds of it at least being safe. So I approach the educational aspects of it from the standpoint of harm reduction. You want this to be something productive. And because it could be something that's life changing positively, that's great. But it could be something that's life changing negatively. I've heard of people who've gone into schizophrenic spells for like years, not with microdosing, but larger doses. But no, I mean, you wouldn't dive into a lake head first without knowing how deep it is. So don't dive into psychedelics head first without knowing whether or not it's safe. And definitely don't go swimming in water if you can't swim. If you don't have any experience swimming, then don't jump in the pool. At least take some lessons.
Well said. Well said. Well, thank you so much. In closing, I love to ask all of my guests to just suspend reality and bureaucracy and the government and all those factors. And how can you envision psychedelics being incorporated into our culture and our society now going forward in a way that is accessible and safe and leads to best outcomes for all?
I would hope that the approach would be similar to what Portugal has and what Carl Hart proposes drug use for adults. Uh, People should have the right to use whatever they feel is appropriate to use, but there should be some safety factors that are built into it. And I think from my perspective, decriminalization, but not from the standpoint of punishing people for the use. If you're selling stuff, if you're selling stuff that isn't what you're advertising, then there should be punishment for that. But in Portugal, a lot of the addiction related crimes dropped because people have access to it. And prohibition doesn't work. We've tried prohibition. Um, it just doesn't work. People are going to get it. I mean, so when you look at the analogous situation, when prohibition was occurring, people were hopefully going to get alcohol from Canada, which was real alcohol, but they might just as well have been getting something that was made up in a bathtub that had a lot of methyl alcohol. So the incidence of blindness went up because people getting bootleg alcohol. So bootleg psychedelics are also just as likely because there's a demand for it. So I think I would hope that yes, there's there's clinical indications for which these medicines, wonderful medicines, can be used, but that there's more of an above ground approach for people who want to use them for things like a spiritual enhancement. And Carl Hart says, if you want to get high, and that's all you want to do, okay, but get high safely. And I think allowing expectation that the government will help do that is probably unrealistic. But if the government will allow programs to be set up that create safety nets and not raid them and put them in jail and what have you, then I think that's our best approach. So Oregon has been criticized for their approach, but Colorado seems to have learned from that. And I think as time goes on, that'll be refined. But I think decrim should come first. If decrim isn't there, then everybody can't get in a clinical trial. Everybody can't afford the psychedelics because I don't know how much MDMA is going to cost. But if you do it with the treatment, you do it with two therapists, and you do it for however long it takes, that's not going to be cheap. So even though people poo-poo microdosing, there's enough people out there saying, no, this is a poison tomato. This is something that people are benefiting from. So let's don't be scared. So my closing comment is our worst fears are the things that never happen.
100%. Thank you so, so much for spending time with us. I
Well,
really,
thank
really
you for having
appreciate
me.
it. Yeah.
I hope I didn't put anyone to sleep, and any misstatements that I made, they're mine. I accept responsibility for them, but hopefully I was able to share in a meaningful way.
I appreciate you and all your incredible work that you have done and given. So it's deeply appreciated. So thank you.
Thank you, and have a nice weekend, and stay safe, stay strong, and stay well.
Beautiful. We'll see you all back in a couple weeks. Thanks for being here.
Bye-bye.
Thank you for listening to today's episode of the Microdosing for Healing podcast. Are you ready to take the next step? Please visit us at microdosingforhealing.com to access our free Microdosing 101 workshop. In it, you'll learn more about our diverse community, our supportive group programs, and discover if earth medicine practice might be right for you. See you in the next episode.